Chapter 6, Long-Term Care, by Kathleen Abrahamson and Karis Pressler. This is a very good chapter. It first discusses the role of families in long-term care and of caregivers. It discusses the operations of nursing homes in the United States, the role of families in long-term care, assisted living facilities, financing of long-term care facilities, and some of the culture which exists in long-term care. And to start, we look at the role of families and the decision to move into long-term care. Defining exactly what caregiving is surprisingly difficult, and it's difficult to identify who is a caregiver. Sometimes the task of caregiving involves instrumental tasks in life, such as shopping or running errands, and it can be difficult to differentiate if this is being done as part of the routine tasks of life or specifically in the role of a caregiver to a care recipient. The chapter notes, quote, "For example, a man may feel that making breakfast for his wife is a caregiving task, whereas a woman may perceive this work to be part of her routine responsibilities." And so, although it may be difficult to accurately indicate who is a care recipient and who is a care provider, it's sometimes useful to ask a patient or their family who is the primary caregiver to begin understanding this question. The burden of caregiving varies dramatically between sexes, cultures, periods of history, and the relationship between the recipient and the caregiver. We know that a decline in a caregiver's health is the strongest predictor for an increase in caregiver burden. Typically, women take on the responsibility of being a caregiver in addition to the other responsibilities they have. Men are more likely to assume the responsibility of a caregiver in exchange or in replacement of a previous role, such as their employment. The burden of caregiving responsibility is typically increased with time, but the caregiver becomes more adapted and more accustomed to the caregiving role. And the burden of caregiving may be mediated and almost eliminated in situations where the caregiver perceives a high self-efficacy and a supportive social network in their role. Defining exactly what long-term care is also difficult. This can be received from families, it can happen in home care, it can happen with assisted living facilities or in nursing homes. It's important to realize that long-term care has general goals of maintaining safety, mobility, functional ability in terms of activity of daily living. Over 90% of residents in nursing homes are over the age of 65. About 46% are over the age of 85, and 72% are female. The decision for a patient to move into a nursing home, in up to half of cases, has little or no input from the actual care recipient themselves. The decision is almost exclusively made by the caregiver and their family, and often in a rushed instance, typically precipitated by a medical crisis. The chance of a nursing home admission increases as caregivers have increased burden, particularly if their role involves continuous supervision, caregiver sleep disruption, and a lack of caregiver leisure time. Younger caregivers report higher levels of emotion-based stress, whereas older caregivers report higher levels of physical burden prior to the care recipient's admission to long-term care. Part 2. Nursing home operations. Currently, 1.5 million Americans live in long-term care. This is from early 2000 numbers. And the number aged over 65 who will require institutional care is expected to double by 2030. I was surprised that facilities are not that large. Over half have under 100 beds, 42% have 100 to 199 beds, and there's only 8% of facilities that have over 200 residents. In America, 2/3 of the institutions are proprietary or for-profit, and this is much higher than other countries. For-profit nursing homes are associated with a lower quality of care than non-profit, and the for-profit homes typically have higher wages, and we'd assume this attracts better staff, but these facilities also have higher levels of nursing turnover and a lower staff-to-patient ratio. The care in facilities is provided by nursing assistants who have around 6 months of technical training, and tasks such as medication supervision and supervisory roles are carried out by licensed practical nurses, LPNs, and registered nurses who have 2 years of education at minimum perform higher level supervisory duties and provide more complex medications such as intravenous. There are 1.5 million full-time caregiving staff in American nursing homes, and nursing homes can have turnover rates as high as 100% for those providing direct care. Turnover is lower in institutions with better leadership, and in particular a consensus-style administration. We also know that turnover of nursing staff decreases when the facility brings in staff retention specialists to address the problem. Part 3. Family involvement in long-term care. The transition to a long-term care facility is often viewed as a decision of last resort. It may be associated with a myth of abandonment. In reality, family members who were highly involved in the patient's care prior to admission to a nursing home are likely to remain involved in the patient's care, particularly if they live close to the facility and if they were the primary caregiver. Although the physical demands of being a caregiver decrease after the care recipient moves to long-term care, other demands, such as financial management, legal assistance, and emotional burden, increase for the caregiver. The role of a family member transitions as well as the patient moves into long-term care. The family become experts in the patient's history and preferences. In the setting of a care home where everything is standardized, regimented, and has the ability to limit a patient's autonomy, the family works to ensure their relative's identity remains intact. They become the watchdog or advocate to help the patients preserve their self-worth, personal identity, and dignity. Family members judge an institution's quality not based on its technical competence, but on the quality of relationships between staff and the resident and the ability of staff to support a resident's self-esteem. Section 4. Assisted living facilities. The definition of exactly what an assisted living facility is proves difficult to constrain. There is wide variation from state to state in both the regulations as well as the function, from minimal to very luxurious facilities. In general, assisted living facilities provide more autonomy to residents, but generally lack 24-hour support as found in nursing homes. On a whole, such facilities may not be equipped to handle more complicated patients. There is a model which is emerging of continuing care retirement communities, CCRC. In these, patients may move into them when they are still independent, and the continuing care retirement community has an assortment of different living opportunities, from independent living to assisted living to nursing home to dementia care. An individual can move into such a facility with confidence that their needs will always be cared for, while at the same time they can always live in the environment which provides the most autonomy and their needs at that time. The downside of CCRCs is that they're quite expensive, currently catering in the United States primarily to white educated individuals. The entry fee may be $100,000 with monthly fees of $1,500 to $2,000. And this is based off of 2002 US pricing. Which brings us to Part 5, financing of long-term care. 98% of long-term care facilities in the United States accept reimbursement via Medicare and/or Medicaid. Reimbursement is based on the facility's case mix of services and patients. Medicare reimburses only short-term illness or specific needs, with mid-2000 per diem pricings of $166 daily. Medicare covers longer-term reimbursement with a per diem of $116. The largest percentage of long-term care funding is out-of-pocket from patients, with in second place 35% coming from Medicaid. It is interesting to note that insurance only covers 4%. Assisted living facilities are generally not funded by Medicare or Medicaid, though some states may allow exceptions to Medicaid being used for residents who cannot otherwise afford to pay. Finally, Section 6, the culture of long-term care. Unlike other aspects of medicine which focus on cure and technologic intervention, the focus of long-term care is preservation of functional status, management of chronic disease, and assistance in the activities of daily living. There is a continual tension and balance between the facility's goals to provide care in a group setting with the individual's goals of preserving individual autonomy and dignity. Residents will work to maintain the outward appearance of a healthy mind and body by displaying their independence while in public, such as refusing to use a walker or a knee brace, even though they may require it. Mealtime is a crucial ritual in the life of long-term care. Residents may dress up for the occasion and even frown upon individuals who, for instance, wear shorts to dinner. As long-term care residents lose contact with their friends outside the facility, they create new relationships within the facility. However, we know that widowers and widows in particular have more difficulty with this, as they can be a stigmatized group, in particular in care homes where widows and widowers are the minority in compared to married couples. I think this was a really important chapter on a part of healthcare which we do not address with enough care or consideration, yet plays such a crucial role in all of our lives. I hope to devote more time in the future to this topic. One of the things that the chapter mentioned which caught my eye is the fact that turnover rates are as high as 100% in some facilities. Now, to me, this is a red flag in any organization that has a 100% turnover rate, and I'd be curious to know why.